with that general idea of trying to pick out treatments based on what somebody has, so HER2 low, is how are we personalizing medication for patients? And of course, one area where we really want to focus on personalizing medication, not that we don't want to do it for everybody, but is triple negative disease, where we've just been really, I think, hit by the poor options available to patients in the metastatic setting, and for patients who don't have a great response in the early stage setting, we just really have such limited options, and we have a really very clear idea of what the outcome is for the majority of patients. And so I think that, you know, we were excited to see data from the IMpassion130 trial with the checkpoint inhibitor atezolizumab added to nab-paclitaxel, but this only benefits a relatively small group of patients in the metastatic triple-negative setting. Tiffany, do you want to tell us a little bit about IMpassion130 and what patients might benefit from atezolizumab?
Sure, I'm happy to. I was just thinking back that it looks like we're right around probably the 1-year anniversary that atezolizumab was FDA approved for this very indication based on IMpassion130. So if you remember, that's a study of about 900 women with triple-negative breast cancer, metastatic disease, or locally advanced unresectable. And it was a first-line trial for these patients. And the backbone was chemotherapy of nab-paclitaxel with a randomization to atezolizumab or placebo. If you recall, that primary endpoint for the study was both PFS and OS. And what we saw in results was interesting. So for the intention to treat population, there was an improvement in progression-free survival. But what was most compelling was seeing the subset of patients with PD-L1 positive tumors. And then we'll come back to how that PD-L1 was tested. But in that subset of patients that are PD-L1 positive, the difference in progression-free survival was more substantial, about an absolute difference of, say, 2 to 3 months and about a 40% or so improvement in PFS. When you move on to looking at the overall survival data, this is where things became a little bit more exciting even. You know, in the intention to treat population, there really wasn't a statistically significant difference in OS. However, just comparing in the subset of patients with PD-L1 positive disease, the group that received atezolizumab had about a 40% improvement in overall survival, with an absolute difference on the most recent analysis of almost 7 months. So while that didn't have the power for a formal statistical analysis, it looked compelling and of interest for these patients. Talking a bit about the PD-L1 positive definition, I think, is important. So in IMpassion130, the assay used to establish PD-L1 positivity was the Ventana SP142 assay, and the definition of positivity was based on the percent of immune cells positive. And so that is in contrast to PD-L1 testing in some of the other solid tumors, where different assays were used and different scores were used, such as combined proportion scores with assays such as the SP263 or 22C3. It's funny presenting this to you, Hope, because I know at ESMO, you actually performed an ad hoc analysis from the IMpassion130 data, looking at other PD-L1 positive assays. And in your data, from what was presented, the proportion of patients on IMpassion130 that had PD-L1 positivity using SP142 was about 40% of those 900 patients. In the analysis that you and your colleagues reported, using SP263, another antibody and assay, there was about 75% PD-L1 positivity by that definition. And I think with the 22C3 assay, about 50% or so, maybe even more. I think even higher than that, maybe over almost 80% or so, were considered positive. And there was concordance between SP142 and these other two antibodies, but only in about, say, I want to say maybe about 40% of overlap. So when we try to, I think, define which patients are most likely to respond to the addition of atezo, my personal preference based on the data I've seen is to stick with the SP142 assay as the predictive biomarker, if you will. I'm curious to hear what others think, and it is your data, so please, elaborate on that if you think that there's other important biomarker nuance that we should be aware of.
Yeah, I think you did a great job of discussing that, and the information, was in the biomarker valuable subpopulation. But, we've, I think, all been very interested in the press release in February of this year from Keynote 355 that suggested in patients, an important population, patients who relapse 6 months or greater after adjuvant or neoadjuvant therapy versus 12 months, that those patients benefited from the addition of pembrolizumab to gem-carbo, paclitaxel, nab-paclitaxel as the options, but only if they had a CPS score of 10 or greater. And as you were talking about, when we were looking at this in the ESMO analysis, CPS scoring is supposed to be positive at 1 or greater. And that was, this huge population compared to SP142. So it is interesting. It does seem like you have to have more positivity, and CPS looks at tumor and ICs and looks at a ratio. And so maybe it is that you just need to have that in the metastatic setting. You really need more of the PD-L1 expression on immune cells. And you're seeing that with this higher CPS score. It's hard to know. I mean, we haven't seen the data presented yet from Keynote 355, but will in this year. So that'll be, I think, helpful. It is a shame in some ways that it's only 41% in IMpassion130, and people have, found different percentages looking at their populations of patients, but it's clearly not everybody. And we still want to improve outcome for those patients.